Excellent questions. I'm Dr. Donna Kinchlow. We're continuing our progress with session 4. As you know, students have given us questions on grief, loss, and spiritual care. They are wonderful questions that possibly could help you whenever you're dealing with people that have loss. What are the best ways to approach patient or family members with the subject of advance directives? Advance directives are legal documents that provide specific details of your wishes when you're not capable of making decisions for yourself. They might come in the form of a living will or a durable power of attorney. Those are the most common types of advance directives. The POA actually identifies the person you choose to make decisions for you. These documents also provide guidance for the medical team, and they give great relief to the family. When the family knows what you want, it gives them peace that they don't have to make those decisions. They know your wishes. When a patient was admitted to my hospital, the question of advance directives, as well as your preferred code status, was always addressed upon admission. It was part of the electronic medical record. If the patient didn't have an advance directive or didn't understand what that was, we would explain it to them. And if they wanted one, it was a referral to the chaplain. You see, the pastoral care team would be the ones to come and help the patient develop and complete that paperwork. If the patient did have a living will or an advance directive, we would request that they bring it to the hospital, and then we would copy it, and it would become part of their chart. It's really funny that people say, if you have a living will or an advance directive, where you really need to keep it is in your glove compartment of your car or your truck, because then you always have it with you. If you're ever in an accident or you're on vacation and you need it, you've got it. You could have a couple places different. You could have it in your car, your truck, and you could also have it where you keep your medical records at home. But note, as far as code status is not a one-time thing. I can't go into the hospital and go, I want to be a full code blue. And then that sticks, and any other hospitalization, I'm still a full code blue. That's code status can change with every admission, It is always addressed, and it should always be asked and documented in the patient's chart. Every admission. If a patient becomes angry and blames you for their losses, even though it's not your fault, you're going to let her yell at you? Would this undeserved behavior be a positive thing? And the answer is absolutely yes. Anger is an intense feeling, and most people feel that when you're angry, that is wrong and unacceptable. But it is the second stage of grief. And even if others don't feel comfortable when angry words fly about the room, stuffing your anger can also hurt you and halt the healing process. Good people get angry and may act out in a variety of ways. If a patient experienced loss and yelled at me, blamed me for whatever, it's indeed a positive thing. This student is so right. And I always think, better me than someone with thin skin. Give me your anger. I can take it. It's okay. And sometimes when it's out and they know they're allowed to vent, they will cry. In my book, A Life Just Like Mine, I share a story of a man who dies. And his wife really surprised me. We had talked about her husband. He'd been very instrumental. He was an elder in the church. He was all these wonderful things. And the minute that he died, A very unexpected feeling jumped out of her. She grabbed a hold of his shoulders and just shook the living tar out of him. Harold, get back here! Get back here! This is not the way this is supposed to be! Get back here! Well, his spirit had already fled his body, and I just watched quietly, in awe, because I never would have expected that from her. It was all right. It was all right. She got it out. You know, no matter what your loss is, anger can show up. I have to tell you a funny story about my husband. When my husband's hospital sold, he was a heating and air conditioning man, and he thought he was going to lose his job. And we'd gone to the restaurant with our best friends, and all of a sudden, my husband starts whacking his dinner roll with his butter knife. Over and over again, he smacked that poor bun. We just watched, wide-eyed, and then we all busted out laughing. Beating a bun, that's not characteristic, but the thought that you're going to lose your job after 20 years is going to come out one way or another. Is it a positive thing? Oh, yeah, it's a positive thing, and sometimes it can be even a little bit humorous. And with Allendale that night, it was really quite funny. We've laughed about that. How can we help people who are going through a difficult time, who aren't spiritual, and they don't believe in any form of religion? That's a question that many of you have asked me again and again. And the truth is, when you stop and think, respecting the patient's choice is key. It is not our job to convert people or to push our belief systems on them. But truly, they're going through a difficult time, and we want to help them. So what's going to help? What is going to help is being genuine, being kind, having a compassionate relationship that's non-threatening and non-judgmental. And for a spiritual discussion, your choice to be an informative advocate for that patient who willingly shares and interprets the medical plan of care. That's how you help them. Give them what they want. And if they're in the hospital and they're having a hard time being in the hospital with whatever reason, if you can keep them informed, they're really going to have a lower angst. If we had a meter on that, their anxiety, as long as they know what's going on, they're going to respect you. And remember that your spiritual care flows through the most common acts of kindness, and that empathetic listening is key. You need to know their stories. Seek that out. If you have a desire to hear my story and the suffering person's story, often they're going to express their pain and their experience. And as long as we allow them that space to examine what they truly believe, what do they normally do for comfort? If they say, I'm not a religious person, I am not a spiritual person, then you start asking, well, how do you find comfort in your life? What gives you purpose and meaning in life? And then you listen. And then simply ask them, is there anything I could possibly do to make things better for you right now? Remember, we can never become authoritarian advisors. We can't be the only ones with the answers, and we cannot rescue them from their distress. But what can we do? We can walk beside them on their journey of reflection. We can be supporters. You can share stories of hope without ever mentioning God or using religious jargon. As their companion through the difficulty, we stand by as they begin to sort out things and create their own solutions. You think of it this way, a child will never learn to tie their shoes if we always tie them for them. And so you have to realize we are there to be helpful, not to give them all the answers. And sometimes they look at healthcare professionals that way, that that's exactly what we're there for, but not always. We are companions, and we aren't always the ones with the answers, but we can give them spiritual care when they're going through a hard time. How would you provide care related to spirituality with a person or a patient that was actively dismissive about the topic? Some only equate spirituality with death, and that is so true. And it's because of this society that we live in that people don't talk about death and dying, that it's a taboo thing. We're just caring about success in life. And again, how do you provide care related to spirituality when they don't want anything? Just remember everything I said in the previous slide. If we respect the person, we may feel it's important. We may feel we need to direct the conversation. But if we think like that, whose needs just jumped over the patient's needs? Do we feel the need that we have got to fix this? Our needs aren't as important as the parent, as the patient's. Some patients may have a very private spiritual care life, and they don't want to share their faith or their beliefs with anyone. I'm in a Bible study, and we were supposed to pair up, and we were supposed to talk about a certain thing, and then also share a prayer request. And the woman I was paired up with, I don't know her very well at all. And she said to me, I don't share. And we do get lists of prayer requests every week, and she never has a prayer request. So she has a very private faith and belief system, and some people protect that, and they may be dismissive because they have a certain group of people they trust, and maybe we're not part of it. Maybe they have a church support group. Some may be bitter with a church. Maybe they've been offended and want nothing to do with anything spiritual at all. Years ago, I had a conversation with the sweetest ICU nurse. She was just a doll. And she shared with me, she left her faith. She got pregnant out of wedlock and met with her priest, and years back, he refused to baptize her baby boy, for he said her baby was conceived in sin. That broke her heart, and it broke mine when she repeated that story. And when I saw the pain as she told that, it just really hurt. So one of the things that you realize is some people have a story of something that happened. And if we know that, it gives us a little bit more of a sensitivity as to where they are right now. I had a heart failure patient who was, he got really offensive and offended and dismissive. I simply said, I'll be happy to pray for you. Whoa, I got a whole anger piece come out. He was in his 90s. He said to me, if you put a donut on my bedside table and ask God to fill that donut hole, he's not going to do it. I'm just saying, just don't even bother. Just keep your prayers to yourself. Well, it kind of bothered me. Why in the world? You're 90 years old. You've got really severe heart failure. You're not going to be here long. I wanted to know why. And so I went back the next day. And because being an educator, you're there to help. And it didn't matter that we'd had that piece of conversation. That didn't bother him. I didn't get snarky. I didn't say, if I want a filled donut, I'll go and get a filled Long John. No, I didn't say that. I might have thought it, but I didn't say that. So when I went to review the education I had given him on his heart, I simply gave him an opportunity to tell me more of his story. So I said, hey, George, could you tell me why you don't believe in prayer? And he didn't mind to tell me at all. You see, his mom had cancer, and they prayed for a miracle, and it didn't come but she believed she was going to be totally healed, and then she died. And that's when he was younger. And so he believed that God didn't answer prayer. He believed that there was no power in prayer, and he just totally left his faith. And I have found that there have been a lot of people that they've either turned from their faith when they didn't get the answer from God that they expected, and they might have been tremendously religious, spiritual people, and they've turned away, and they've taken their whole family and turned away because their belief in God relied totally on answered prayer. And they never had the thought that maybe heaven would be the best healing a person could ever ask for. But for them, they're done. And that's where this man was. But it was sweet that he didn't mind to share the story. And his mom had died of colon cancer, and my dad had died of colon cancer. And so we had another commonality, and I wasn't judgmental, and he didn't mind to talk. And we talked about his mom. So ultimately, we need to be realistic. We cannot always erase the spiritual suffering ingrained on these dear ones' hearts. We can't go back. We can't solve their spiritual issues, nor convert them or correct them. We can't bend them into the peace that we experience, but we can be consistent caregivers, and we can always listen, and they will know we care no matter what. Even just talking about his mom, I think, made that 93-year-old man feel good. He knew I cared. Does spiritual distress get misconstrued for depression or vice versa? That's a wonderful question. A paraphrase of defining spiritual distress from NANDA. What exactly is it? It is a disruption of the relationship between a person and their higher power. And that relationship's in jeopardy. You've got inner resources and connection to the divine higher power or beliefs about life and death, and they've been challenged or compromised. And what's the patient actually going to be showing you, manifesting? What is spiritual distress going to manifest itself? Well, they're going to be in a state of despair with negative self-talk. They'll have what I call dis-ease of spirit instead of disease. You hyphenate that. And they can deny their faith. Their routine ritual things that they normally do, if they sang in the choir or they taught a Bible study, and now they don't do any of that anymore. Practices will cease. They shut down. They want to avoid personal discussions. Anxiety and depression can be a part of spiritual distress. And you do remember, depression is that fourth stage of grief. Now, there's a difference between the mental illness of clinical depression and a person going through the depression stage of grief. These people need reassurance and support, and they still have the ability to appreciate your kind gestures. They have the ability to be thankful for your relationship and the fellowship that they receive. And when it's the depression stage of grief, the stage will pass, and they'll get through it over time without the need for any kind of professional help. But symptomatology of a person who's suffering from clinical depression is going to include these things. They are blind to good intentions of other people. The negative thoughts bar any positive. An inability to see anything but darkness without any hope that a light source even exists. These dear ones need professional help. The challenge for clinicians is not to label true clinical depression as grief. And again, it goes back to have an understanding of that spiritual history and also your physical, mental status. How do you tell the difference between someone who is elderly and depressed versus someone that's dying? Both can show similar symptoms of increased fatigue and sleeplessness. Yes. So, depression is a normal emotion now and then. However, If it lasts for weeks or for months, it needs to be addressed by a healthcare provider. The symptoms of depression differ from person to person. Fatigue and insomnia, or maybe even oversleeping, can occur. It's a mood disorder, and it may not show up as sadness in the elderly. And it may be more a lack of motivation and interest. Now, dying can mirror some of the symptoms of depression, but the physical signs, you have to remember that physical body and cardiac output and perfusion. You want that blood flow. When you are dying, you have decreased cardiac output. Your blood is shunted from your major organs to your major organs from things that aren't as important to keep you alive. What does that mean? The skin is going to get cheated. It's going to be cold and pale and mottled with a blue and purple tint. Your respiratory assessment on someone who is dying, you're going to have a change in my rate and my depth. And oh my, if I start gasping or having gurgling noises, that's going to be very uncomfortable for family. But medications will be available to reduce those secretions, and you'll maybe have an order to suction if you need to. When you are dying, periods of apnea, A meaning absence, Nia being breathing. You have a little bit of absence of breathing. So what do you have? You've got several seconds where I'm not breathing. And nothing. And then maybe, yeah. And you'll have some physical symptoms, changes in my pulse, my blood pressure, my cognition. And some people, when they're dying, have hallucinations. With proper pain management, the death of a patient can be very calm and peaceful, and we know how to take care of all these signs and symptoms. Greatest difference between a depressed elderly person and a dying patient is going to be your physical presentation and your physical assessment. How should we respond when a patient says something like, "My life is meaningless and I have nothing to live for"? Wow, this is pretty deep questions that can create an awful lot of unease to your nurse and healthcare providers. We want to respond to this in the appropriate way. The person is pointing to severe hopelessness and despair. We need to acknowledge it, and we need to verbalize the distress the person's sharing. It is difficult to see meaning when we're in distress. That's something you can say. Something that I would probably say, you have to realize that you can look at all kinds of cookie cutter things to say, but what's your personality and what's your relationship with that person? I'd want to know something. I would ask this: what seems to have triggered this feeling that life is meaningless? You see, I've taken what they've said, which gives them understanding that I'm listening. And then I would ask, is it connected to a loss? Because my wondering is, is this something that just showed up with your illness, or is this something that's been bothering and carrying through, that maybe you lost a child, or maybe something's triggered an event memory? I have nothing to live for. We don't always have the right answers. But in this case, the patient had the courage to express deep brokenness with you. If you can determine the root cause of those feelings, the conversation's already begun. Maybe they have a broken relationship and the patient is yearning to reconcile. It reminds me of a friend of mine who was dying of lung cancer, and I'll never forget how thrilled he was that his brother, who he hadn't seen in 20 years, was coming to see him. So we don't know what it is, but once they begin to talk, you can ask. And if they're willing to continue, if you're able to know the person's story and they're willing, You can even conduct a life review, and you and the patient will be able to see the things that did hold meaning. If the patient's in a very dark space and these statements are made and he's shutting down, these can be signs of suicidal thoughts. And in that case, you want to involve a mental health professional. There are no right answers, as you know. You can throw out a question, but since we're not in the room, we don't know the dear person. But if they're saying something to you, you become the most valuable person to help uncover what is the true heartbreak. What's a good way to bring up a help program for someone stuck in the stages of grief that is decreasing their value in life? Years ago, there was a negative stigma surrounding getting any help from counselors or mental health teams. Some would say, "I'm not crazy. I can handle this." Well, this is a common phenomenon, and it prevents people from healing. Not getting help is not a sign of courage. It's a sign of weakness, and it's a source of embarrassment and shame to some people. That's how they view it. Offering grief counseling or therapy requires sensitivity, an emphasis on the courage and strength it takes for a person to want to move forward and improve their coping skills is a very beneficial point to make. It is helpful if you're familiar with a grief group. It can even provide some true testimonials from people that you know got through this. For example, we have a grief support group at our church. The woman that leads it lost her husband. I also know of a woman who became a grief counselor after the death of her husband, and another friend that lost her teenage daughter in an accident. And she took that and for her doctorate created a grief study program. Providing a list of resources can be helpful, but knowing how the patient learns best or what medium they would feel most comfortable is really good, because that will help you know that they will follow through. There might be some Zoom meetings where the person can participate in the comfort of their own home. Today we have so many resources available. Knowing the patient's story, asking what they prefer, and what would they consider. Let the person know you're offering these helps because of love, and you only want to help them move ahead despite the loss. I'd also connect with a support group, and if that person is a family member, find out if you can accompany them to meetings. The greatest thing is getting help. Being stuck in that grief, in that complicated grief, is a painful thing, and some people just can't move through it. We can do the best we can. Some will jump in and get help. Others, we just have to meet them where they are. Is silence an okay thing to do when you're grieving or when someone is grieving? Silence is a very okay thing to do. It's almost a skill that we have to learn, because for some of us, it's like we have to be the chatty Cathy. We have to be the person that's always making conversation, filling space, the air with something to say. Silence can be the best gift you give the one who's grieving. Freedom to chill and be still. Being comfortable with silence is an appreciated skill. We don't need to fill the air with verbiage, just like music blaring at a restaurant, and you can't change the station and you can't turn it off. We don't want to be like that. For someone just needs you to be there. Maybe hold a hand, touch a shoulder, an arm. Just look at someone with love across the room. It's more than okay. I understand it's a huge part of our career to care for patients and help them have a dignified death. But how do you prevent the grieving process from occurring to us as healthcare professionals? What is your advice for providing the best care possible, but keep ourselves detached just enough to prevent decreased morale among ourselves? Several of you have asked this question in different formats. And during the previous session, I think we may have touched on this topic. But let me assure you, more of your patients that you care for are going to live than they're going to die. You're going to save lives. You're going to use critical thinking. You're going to help diagnose people's issues. You're going to have so much love, so much thanksgiving tossed at you from your patients and your families and your peers. The death of a patient is sometimes expected and welcomed by everybody, including you. If someone is dying on the unit I worked, one day the family loved the staff so much they preferred to stay with us and decided not to go to the hospice unit. They wanted to be with us. That gave us a shot in the arm. There are times you will become so close to the family and they're never going to forget you. And I want you to be prepared of that. It isn't so much that you're detached as much as it is you realize that being who you are touches the lives of your patients and your families. You may be a link during their chemo. You may be the last person that sees them take their last breath, but no matter what you do, you're making memories. I went to the dentist and I was reading. I could feel the woman across the room looking at me. I looked up and smiled at her and she said, "Aren't you that IV nurse?" And I confessed. And she said, "You always did Daddy's IVs when he came in for his chemo in the hospital." I don't know what possessed the two of you, but every time you and Daddy got together, you told each other jokes. Daddy would get so tickled. And I remembered him. And she said this, "You never saw Dad as someone who had cancer. My dad loved you." And then she nailed me. "We talked about you at Daddy's funeral." Now, you need to realize that there's going to be more encounters like this that will keep your morale. Those moments when you cared and you didn't leave your personality at home. Those moments when you saw the patient as a sweet guy who loved jokes and so did you. I had no idea. I had no idea. But they're going to tell you, and it'll be you they tell, and you're going to realize that being a part of that process, wherever you were in that stage of death and dying, you made a mark. You made an impact. So, what is my advice? Get yourself a journal. I have a prayer journal. When I worked, I kept a prayer journal, and I would write my prayers and my patient family stories. I worked 12-hour shifts and weekend option most of my career so I could go to school. I went to school all my life. I was a diploma grad. I got my bachelor's. I got my master's in nursing education. Then I got my doctorate. So I did that craziness that they, Institute of Medicine wants you to be educated, wants you to be educated. And so I just kept jumping higher and higher. But I was an odd duck, I can tell you what I did, but not everybody's an early morning person. I got up at 4:30 in the morning, fixed my coffee, jumped in the shower, put on my makeup, got dressed for work, drank my coffee, read my Bible, wrote my prayers, wrote my thoughts in my journal, and on the way to work, I either listened to Christian music or I listened to Dr. David Jeremiah from out in California. And he would be giving a spiritual talk. Now, when I came to work, if I learned something neat, and I had the privilege of taking care of other Christian patients, which where I work and where I live, there's a high number of Christians, we would get into conversation and I'd share what I learned. You have to find what keeps you. I also worked with some of the finest nurses and nurse managers. That will keep your morale from taking a nosedive. I'm telling you that. I used to say I would never want to work for a nurse manager that I did not respect. And in most of my career, I had some really top-notch nurse managers. And my coworkers, they were there for me. And that's the other part. When you're thinking about taking care of yourself, it's not so much about being detached as much as it is having someone put positive deposits in your emotional and spiritual bank account. And I'll do another video on the problem people in your life, and you'll understand what I'm talking about. So this ends the fourth session of Excellent Questions, which actually focused on respecting non-religious people. What do you do with depression or dying? Offering grief therapy, spiritual distress versus depression, and maintaining your morale. And again, I thank you so much for your questions and for this time together. And I'm hoping that I'm helping you. And if you ever need me, you know how to get a hold of me. Thank you so much.